Hello, and this will be your Occupational and Environmental Lung Disease lecture. From me, I am Dr. Carla Barbon. I'm actually a batch 2014 alumni, and these are my credentials. So we go on with the lecture objectives. This is quite a wordy slide. I specifically made it that way so that it will serve as your review for your exams or for your future use. We will start with the introduction and then we will go to discuss just a few diseases that you may probably see in your practice with ILD and work-related asthma. And then we will end the lecture with the preventive measures to minimize the risk to these. My friendly reminder would be to get a cup of coffee, for this is probably your most boring topic. So what is occupational lung diseases? It's uniquely and specifically related to factors in the work environment. Ibig sabihin, kasalanan ng work or yung environment sa work. So usually mga construction worker, mga sandblasting miners, ganyan. Occupational exposures also contribute to development or worsening of common respiratory diseases. So for example, that patient already has COPD and went into this kind of work, nag-exacerbate, that's also called occupational lung disease. Most occupational lung disease are caused by repeated long-term exposure, but even a single but severe exposure to a hazardous agent can damage the lungs. And we'll go right there. Now, occupational lung diseases are not always reversible, but they are definitely preventable. So, yun ang pinaka take home dito. Kaya, we want you to be aware of these lung diseases because they are preventable in your workplace. Diba? We start, of course, just like every other disease, with occupational and environmental history. This is the step one, and this is your most helpful tool. What is your objective for the history is to determine if the lung disease is related to the trabaho or the occupation or an environmental exposure in the workplace. Yun yung goal mo. That after the history, I could tell the causality of this lung disease if it came from the trabaho or the work of my patient. The occupational history has two important lines of inquiry. It should answer the following. Is this a worsening of an existing underlying pathology? Meaning, pumasok ba siya ng may sakit at lumala lang? Or is this a result of an environmental or exposure to the occupation of the patient? Bago, pagpasok niya wala, dun siya nagkasakit. Ulit, is this an existing underlying pathology na lumala? Or is this bago or came from a result of an environmental or occupational exposure? The occupational history starts with screening. Basically, you ask, what is your line of work? What kind of work do you do? Have them describe what they do. No? Don't just ask the job title. Pag sinabi na, I work as a factory worker, can you tell me more? What kind of factory you are in? Ano yung material? What is exactly na dun sa process flow you are in? Nagbabalot ka ba? Naglalagay ka ba ng chemicals? Ganon. You go to the nitty-gritty details so that you understand the exposure of the patient. Then you can ask the patient talaga, do you think your health problems are related to your work? Kasi I had this patient before na lumapit talaga siya sa isang consult and he said na, I think nung nilipat po ako ng workplace from a different area, same company pero different area, lumala po yung asthma ko. That's a clue for you now, okay, baka this is an occupational lung disease. You ask also, mas better or mas worse pa siya when the symptoms are better or worse at home versus sa work. Are you now or have you previously been exposed to the following? So, ang important dyan is not only the current exposure but also the past exposure of the patient to possible lung irritants. So, these are your sample questions. Just read on it. Okay? The occupational history components. Number 1, what is the exposure? Number 2, job description. What do you do and how do you do it? Number 3, to identify any chemical exposure or other hazards. So, when you Google things, ang bawat chemical has this material safety data sheet. Doon nakasulat yung mga known toxic exposures or known diseases associated with the exposure to that specific chemical. Lahat may ganon. So every chemical has a material safety data sheet. You ask how long the patient is been exposed to this chemical. Matagal ba? Sandali lang? When it started, when it finished, and how often it occurred. Once a day, the whole shift. That's how you ask. And then you ask the intensity of exposure. So this is a safety data sheet. This is an example of it. This is a data sheet for formaldehyde. Your goal for your history is actually to determine causality. Kung yon ma-accomplish mo in your history, then you're good. How to determine causality starts with determining temporality relative to exposure. When did the symptoms start? Was the symptom reversible? Do the symptoms improve when the patient is no longer exposed? For example, nung nag-holiday po ba kayo, nung nag-leave po ba kayo sa trabaho, did the difficulty of breathing get better? Or pag weekends, yun yung favorite na tanong, pag weekends, and when you go on your break or day rest or rest days, did the symptoms abate? You also ask dose and response gradient. Are the symptoms worse when performing specific tasks in areas with high exposure? You also ask the strength of association. May other workers po ba kayo have the same symptoms as you? You ask for specificity. What are other exposures or causal factors that could be responsible for the same symptoms? Baka naman pala this patient is a heavy smoker and the dyspnea that he feels or the chronic cough or sputum that he feels may not come from the exposure in the workplace but actually from heavy smoking. Consistency. Are there other reports of the same symptoms associated with or caused by the same exposure? For example, asbestos. That is also already a proven carcinogen. Okay, pwedeng mag-coffee break. This next set of slides are text-heavy and boring, but I won't be including them in your exam. You can save it for future use, I think. So these are the sample questions you ask your patients. How is your symptoms sa first shift sa Monday versus sa Friday? Yan. So, mas malala po ba siya sa Friday? Tapos, pangit sa Monday, and then good sa Saturday, Sunday when the patient is at home. Is any kind of mask or PPE used in the workplace? What kind of mask? Is this N95? Is this a respirator? And of course, you know that an N95 to be really, really effective should be fitted. May not happen. Even us in the healthcare field, hindi rin yata na-fit ang N95. But the ideal way is for every N95 or respirator to be fitted. You ask, as I said, is anyone else symptomatic? Do you eat in the workplace? Do you smoke in the workplace? And then the PPE questions. So these are sample questions to ask for exposure levels. Kasi, of course, the common worker wouldn't know the exposure masyado, no? So these are surrogate markers to ask how bad the exposure is in the workplace. Do you see dust or mist in the air? Kasi when the dust is already visible, you can probably think na, okay, heavy ang exposure ng patient na ito. Can you see your co-workers or nearby objects clearly? Ibig sabihin kung haze na siya, sobrang kapal na ng mga dust na nakasuspend sa air. Are surfaces dusty or damp? Okay yun, magandang tanong yun, di ba? Is there a strong smell or taste? The following. Specific exposures in the workplace include asbestos, silica, sand, dust in the mining or quarrying, sandblasting, solvents, or degreasers. And ito yung mga, I would say, red flags of jobs of your patients. So for example, you have a patient with chronic dyspnea or chronic cough, and then I always like, ano po yung line of work po ninyo? So, pag na sinabi niya, I work in the shipyard, okay. Yan yung magic word, shipyard. I'm a construction worker. Ano yan? Red flag. But you should know na many construction workers smoke as well. So you have to delineate. Okay, dun papasok yung goal mo to determine causality in the history. Okay. May isa pa, mga artists. You ask, ano po yung medium ninyo of uh, a medium of choice for your art? Baka naman sand ang kanyang work, di ba? And any dusty work, ano mga dusty work? I guess yung mga cleaning companies who go to your house and really strip your house clean, baka they are part of the emerging occupation that is exposed to dust exposures. Okay. The PE of occupational lung disease is easy because the most striking finding in these patients is actually nothing. There's relative absence of any physical signs. So, pero i-PE mo pa rin. Of course, we go after your S, your O, we go to diagnostics and monitoring. What diagnostic test we do? Kasi walang PE findings eh. Talagang siguro 90% of your diagnosis comes from the history to be supplemented with your diagnostic tests. The routine tests would include chest x-ray, pulse oximeter, pulmonary function tests, arterial blood gases. And for the advanced cases, siguro marirefer na yan sa pulmonologist, magpapa-chest CT scan na siya. Or pag kailangan namin ng more invasive sample, then we do bronchoscopy with biopsy and lavage. So this is a picture of a patient undergoing bronchoscopy. So there's a scope na parang endoscopy, but then it goes into the trachea, and then it goes into your terminal airways, and then we do washing, and then we do sampling or brushing. Sometimes we do biopsy. Next would be environmental sampling, pero hindi na siguro yan medical field. Okay, clinical correlation. Ito na, medyo, ano na siya, a little bit less boring. So we start with the respiratory tract and defense mechanisms. Okay, so per part of your respiratory tree, so sa nasopharynx, we have nasal hairs. So basically, sa upper part, you have physical barriers plus the mucociliary apparatus. Yun yung nagwawash or nagmamop or nagbabrush ng mga dumi, pabalik para you spit it out. And then you have immunoglobulins A that is secreted here as a part of your immunologic response. When you go further down, you have now the cough reflex. So, di ba? It's actually the body's response to foreign bodies. Now, pag nag-cough, it's trying to expel the foreign body out. The immunoglobulins na nagkaroon na siya ng additional letters. Meron na siyang IgG tsaka IgM, not just the IgA. And then latter or dun sa distal parts of the airways, we have the alveolar macrophages, lymphatics, alveolar lining fluid na maraming laman. And this is where your cell-mediated immunity happens. Of course, we have also the factors influencing the effects of these inhaled particles. Meaning, sila mismo, yung mga inhaled particles mo, they have this innate characteristic that can cause you to get sick. At syempre, hindi naman lahat ng mai-inhale mo magkakasakit ka. So, may mga certain particles that can really make you get sick. So, those are physical factors and chemical factors. So, pwede sa size, sa shape, how soluble they are. So, if you see this image, the higher parts, ayan. The higher parts, doon nagde-deposit yung mga more than 3 micrometer particles. And then, ang makakarating lang sa alveoli are actually those that are less than 0.5 micrometers. Doon sila magde-deposit. Somewhere in between, dito siya sa may tertiary bronchi or bronchioles. So, yung malalaki dito sa taas, so by logic, yung maliliit, nag-e-end sila sa dulo. So, if you think about it, those particles are very, very small, they tend to lodge in the distal parts of the airways. The pulmonary response to respiratory inhalants can be divided into two. Your acute responses and then your chronic responses. Yung acute responses at that time that you were exposed to that exposure or inhaled particle, you can have irritation of the upper airway. Uubuhin ka, mangangati yung lalamunan mo, sore throat, itchy throat, simple things like that are already irritation of the upper airway. Obstruction, the physical finding for an obstruction is stridor. So, pwedeng physical obstruction of it or pwedeng namaga because of an inflammatory response, nagsara yung upper airway, stridor. When you go a little bit further or distal to the terminal bronchioles, your bronchi can constrict, so that will cause wheezing. So acute responses pa, alveolitis and edema. The chronic responses is the development of these following diseases. So asthma, fibrosis, so pag sinabing fibrosis, that's peklat, no? Nagpepeklat or kumakapal yung areas of the lungs that used to be inflamed. And then the development of cancer. These types of responses are dictated by the site where the particle is deposited, the dose, how long you are exposed to it, and the patient's susceptibility. As individual host factors are difficult to identify, it's very, very difficult to protect all workers. Merong patient na very sensitive, merong patient na parang wala lang, hindi tinatalaban. But for the benefit of everyone, minsan, of course, our safety officers would say that to wear appropriate PPEs. Basic principles to remember are easy. Remember that most are difficult to distinguish from disorders of non-environmental versus occupational inward. Mahirap talaga siyang i-decide. It takes repeated testing, consistent and close monitoring. Sometimes you have to really draft or graph the symptoms of the patient para ma-gets mo yung temporal profile and causality of the symptoms. A given substance in the workplace can cause more than one disease. The etiology of many lung disease has many factors, and these factors will interact with other factors. So, patong-patong na factors na. The dose of exposure is an important determinant of the proportion of people affected or the severity of the disease. Number 5, individual differences in susceptibility to exposure to exist, as I said earlier, and the effects of a given environmental lung exposure occur after. Important. Ayan. After the exposure with a predictable latency. So, like asbestos, when you get exposed today, the symptoms will come out 20 years. So, kung ngayon, 30 years old ka, 50 years old mo pa siya mafe-feel. After the exposure of a predictable latency. 3 common characteristics of this disease? Well, basically, paulit-ulit ako dito. These symptoms are aggravated by a workplace exposure. They are preventable. And kaya this is a topic of interest for many, occupational medicine and us pulmonologists, and may vested interest din dito ang employer and the employee because they are potentially compensable. Ibig sabihin, if you're able to prove that this disease is caused by the exposure of this patient in the workplace, tas may nakitang breach in PPE or inadequate PPE, then that patient deserves a compensation. For that would entail a lot of confirmation. Siyempre, hindi agad papayag yung mga company na mag-compensate na lang basta-basta. So it's up to you as a doctor, as a clinician. Your 2 broad types of occupational lung disease have 1, long latency. So that's what I said. Asbestos yan. Silica. So asbestos can cause lung malignancy in the long run. Or pneumoconiosis. It's an interstitial lung disease. Or nagsisira-sira yung interstitium, not necessarily the alveoli parts, the interstitium of the lungs. And then we have patients, disorders with short latency. So these are pneumonitis, namaga, or this is reactive airway disease. So yun yung single event that's causing reactive airways or hyperreactive airways. This is a long list of occupational lung disease. Not all are, for example, COPD is not exclusive an OLD, but it can be exacerbated inside the workplace. Parang, tuberculosis, di rin siya laging occupational lung disease, pero it is listed here, depende sa exposure sa patient. This is malignant mesothelioma. It is from asbestos. Ito rin from asbestos. Ito rin from asbestos. Okay, so the first part of your most common OLDs are the ILDs or the interstitial lung disease. Yung pinaka-important dito sa interstitial lung disease is actually the chest radiograph and the chest CT scan. They have characteristic image or they have characteristic image, and may marinig pa kayong mga terminologies that are specific to different diseases. Okay, ILDs have been more closely associated with an occupational etiology than any other category. Hindi pneumonia ang usual na nagkukuha ng patient sa trabaho, but ILDs. Most of the ILDs really come from OLDs, like silicosis or pneumoconiosis. Of course, may mga ILD from autoimmune disease, so that's a different category. Although individual susceptibility plays a role in mineral pneumoconiosis, they are generally considered to be caused by progressive accumulation or nagkakadagdag-dagdag na, patong-patong na, of toxic dust in the lungs, so repeated exposure. Classic examples are silicosis, asbestosis, and coal workers pneumoconiosis. This is the parang pathophysiology of a pneumoconiosis. It starts with particle deposition. Yan. Na dahil it's really small, as I said earlier, less than 0.5 micrometer will go to your alveoli sa dulo. When it reaches your alveoli, it can trigger your alveolar macrophages to be activated. It can affect your epithelial cells, and then it can release your mediators. So, start tayo dito sa macrophages. Yung macrophages, because we know it's parang soldier of your immune system, it will cause inflammation of your alveoli. The mediators that are released when there is a foreign body at the alveoli will cause inflammation also. Ayan. And when the foreign body or particle interacts with epithelial cells, they will lose their integrity. Magbubutas-butas yan. So, papasok dyan yung mga mediators, mamamaga. Okay, then everything will go to this red block here. So, alveolar inflammation. The alveolar inflammation will then cascade to interstitial inflammation. Of course, in the process, magkakaroon pa yun ng mga inflammatory mediators, fibroblasts, kaya nagkakaroon tayo ng fibrosis. Magtatawag pa yan, maghahatak pa yan ng mga ibang macrophage kasi nga it's a cascade of inflammation. Once mag-start magkaroon ng alveolar inflammation, magtatawag na yan, uy, meron ditong namamaga. Tara. Magtatawag pa yan ng fibroblast. Uy, tara. Magkapekla tayo dito. And then, eventually, it will cause interstitial inflammation, will cause fibroblast proliferation, deposition of extracellular matrix, and will cause pneumoconiosis. We start first with the first mineral pneumoconiosis, which is silicosis. This is induced by the inhalation of silica or quartz. Saan nakikita yan? Mining. Ayan, ito yung number 1. Mining. Mga clue mo dyan, yung mga nasa quarry, which is common here. Romblon, ayan. Processing of stone and sand, sorry. So I have a patient, I think we have a patient when I was a resident na worker siya ng floor tiles. Isang sikat na floor tile maker. Meron siyang mineral pneumoconiosis. Pottery or ceramic manufacture is also a risk factor, and sandblasting. Other disease associated with silicosis is COPD. Because of structural destruction from silicosis, pwede magka-COPD. TB, meron silang, they usually coexist. Apparently, with the presence of silicosis, it will increase your predisposition to get the tuberculosis. Lung cancer can happen in the long run, and systemic sclerosis. So, your silicosis can be acute or chronic. Acute silicosis can develop after exposure to a mabiglaan, high concentration of respirable crystalline silica. The symptoms happen within a few weeks to a few years after the initial exposure. So really, it's not enough to ask lang for the past few weeks. Talagang you go way back nung una pa. Nung pagpasok niyo po ba siya, there was an exposure of silica. Grabe po ba yung gabok sa workplace niyo? Would you remember a certain incident na may nag-leak or may natapon? Okay. The presentation will present as a rapid onset of symptoms. So, dyspnea, cough, usual naman ng mga pulmonary symptoms. And minsan, they come to you na wala, the chest x-ray is normal. So, as I said, history is very, very important. Your PE can show crackles. The diagnostic is none, kasi this is acute silicosis. Later, we'll see. what you can do is to get an arterial blood gas or a pulse oximeter to check for oxygenation. And then, to see or document silica inside the airways, we do bronchoalveolar lavage. And to see if nagkaroon ba ng limitation in the function of the lungs, we'll do pulmonary function test. Nagkaroon ba siya ng COPD? Nagkaroon ba siya ng obstructive lung disease with a silica that was inhaled? So we do PFTs. Usually, bumababa yung FEV1, bumababa yung FVC. The imaging of acute silicosis is defined to have bilateral, diffuse, ground glass opacities. Pag sinabing ground glass opacities, basically it's just haziness. Ayan. Ito, haziness yan. Hindi siya low bar, hindi siya puting, hindi siya solid white. It's parang grayish na magulo. And then because of it, hindi mo na makita yung borders of the heart. These features may progress from a pattern. So mag-start to sa lower zone. Ayan, nag-start sa lower zone. Tapos magdidikit-dikit siya, pwede siya magdikit-dikit to large masses. Pag lumalala na siya. When you do a CT scan, so when you do ILDs, you do high-res CT scan, smaller cuts, so that you can really see the integrity of the interstitium of the lungs. In the most common HRCT finding in pulmonary alveolar proteinosis, is crazy paving, while the most common finding in acute silicosis is dependent consolidation and nodular calcification. So you can have pulmonary alveolar proteinosis when you have silicosis. There's also hilar lymph node enlargement. Dito, your hilar, so let's see. Your hilar lymph node enlargement is around, mahirap i-delineate dito. Pero this is your hilum. So this one is a bulk of lymph nodes. Your nodular calcification, we have to zoom this a little bit, okay? Chronic silicosis includes simple silicosis and PMF, or progressive massive fibrosis. They develop slowly and appears 10 to 30 years from the first exposure. Parang asbestos, mabagal. Many years even after nag-resign na, nag-retire na, doon lang nagkaroon ng sakit. So you will see progressive coalescence of silicotic nodules that leads to the replacement of the upper lobe parenchyma by the nodules and will cause air trapping. So kaya nagkakaroon sila ng changes sa pulmonary function tests because it can cause air trapping and emphysema in the lower lobes. Kasi nahila ng mga nodules sa upper lobes yung mga parenchyma sa lower lobes causing air trapping and emphysema. This is a sample radiograph of a simple silicosis. It's characterized by maliliit. Ayan. So you can see there are small, sharply marginated, small rounded opacities. Ayan. This one. So ayan, bilog-bilog sila. Para kang nagsabog ng millet seeds. Pero parang miliary TB, no? But this is not the distribution of miliary TB. Kasi, this silicosis is, nakikita nyo siya, it's seen in the upper lobes. Simple silicosis. Small circles at the upper lobes. Chronic silicosis, so as I said, RPMF, progressive massive fibrosis. These are already complicated or conglomerate silicosis, and the lesions are actually bigger now. It's 1 centimeter or greater. Ayan, ang lalaki na niya. Okay. These nodules can contain air and calcification, and like the simple silicosis, it's seen in the upper lungs. Okay. Clinically, they would present to you with a history of a silica exposure, a chest imaging that shows opacities consistent with silicosis. So that's why I took the time for you to demonstrate the x-rays of a patient with silicosis kasi they really have characteristic x-ray findings. So when you're used to seeing an x-ray, na ito pala itsura ng x-ray with silicosis, you can now pattern, parang hugutin yan sa memory bank. Parang, hey, nakita ko na to before. Itong mga dots ato at the upper part of the lung. So that's your silicosis. And then, make sure that there's no other diagnosis that could explain your symptoms. The treatment, none. There is no proven specific therapy. Of course, we stop the exposure and avoid further exposure. If the patient is smoking, you ask the patient to stop smoking. This is to prevent further deterioration of the already diseased lung and decrease further the risk factor to develop lung cancer. Steroids has controversial evidence. So far, it's not yet generally recommended for the treatment of silicosis. The prognosis is unknown yet, but definitely the lungs will continue to decline. Our second disease is coal workers pneumoconiosis. So yung first one is na-expose sa silica, silicosis. Ito naman, mga coal workers na-expose sa mineral dust inside the mining. And this is the example of a lung of a pathological specimen of a patient with coal workers pneumoconiosis. Ang pinakamadali dyan, they're caused by coal dust particles. And depending on the location and type of the mining activity, they will have high concentrations of also silica. Inhalation of coal dust tends to cause formation of, ito, ang keyword, coal macules, peribronchovascular coal macules. CWP has similar features to silicosis. Why? Kasi, well, yung coal mine dust kasi also has silica. Okay? But it is classified as a separate disease due to its rather characteristic pathology. This is the imaging. O, di ba magkamukha sila? Also in the upper lungs, nodular din. Ayan, nodular din. Upper lungs din sila both. The small rounded nodular part is less than 1 centimeter with a preferential of the upper lobes. Eventually, ito na confluence na siya. Teka, meron pa ba dito maliit? Ito maliit. Ayan. Leads to the formation of a complicated CWP with PMF. So yung PMF, not exclusive to silica. Pwede rin siyang makita in coal workers pneumoconiosis. Medyo patong-patong, overlapping yung disease. What you can do is to get a chest CT scan. So this confirms the upper lobe conglomerate of masses. So what you can do here is actually do a biopsy. Ayan. When you do a biopsy of these consolidated areas of the lungs, you'll see this specimen. So this is actually your black coal dust. Ayan. Okay. So PMF secondary to CWP. Okay. Ito. Siguro this one you're a little bit familiar. Asbestosis. But medyo ano na to historic. Pero lagi nasa exam. So this is an example of your chest radiograph from a patient with asbestosis. You have a lot of shaggy fibrotic tissues. Ayan, mga peklat-peklat na. Your CPA or claustrophenic angles is blunted. This may be water or this may be actually thickened na yung pleura ng patient. Asbestosis specifically refers to a kind of pneumoconiosis because I said, di ba nga, a pneumoconiosis is a general term. Pwede siyang silica, pwede siyang coal workers, and now nasa third tayo, asbestos, caused by inhalation of asbestos fibers. This disease is characterized by a very mabagal, slowly progressive diffuse pulmonary fibrosis. Napakabagal na pagpeklat ng lung. Yun, in Tagalog. Your exposure is actually mining and exposure to asbestos. Saan ba nakikita yung asbestos? Asbestos is a very old material used for cement, with insulation, with shipbuilding. But then became, as time goes by, na na-prove nila that asbestos is very carcinogenic, tinanggal na siya sa mga new construction materials. So, makikita mo ito, ang clue mo dito is when a patient is a construction worker in the 1970s, ganyan, or is renovating a very old building because chances are that old building has an asbestos. So actually, PGH has an asbestos scare before when I was a fellow. So parang may tinanggal silang something dun sa isang old building. It turns out it has asbestos. Kasi lumang building na siya. Most patients are asymptomatic for at least 20 to 30 years bago siya magkaroon ng symptoms. The latency period between exposure and symptoms is inversely proportional to the intensity of asbestos. And your earliest symptom asbestosis is actually dahan-dahan na onset of breathlessness with exertional or exertional dyspnea, which progresses even in the absence of further asbestos. Meaning, nag-retire na, hinihingal pa rin yung patient. Hindi naman smoker, no other risk factors, except for a very colorful history in the employment. Other symptoms, cough, sputum, and wheezing are actually unusual. Talagang hinihingal lang sila. As asbestosis progresses, patient may develop bibasilar rales and clubbing. Clubbing because eventually, when the lung tends to deteriorate, the areas where oxygenation will take place will deteriorate also, causing hypoxia. So, yun. Therefore, in the long run, clubbing. This is a chest x-ray of a patient with early asbestosis. So, di ba, yung kanina, nakikita sila sa upper lung. Ngayon, yung silicosis sa upper lung, yung CWP sa upper lung, yung asbestosis nakikita siya sa lower lung. Ayan. Ayan. It is associated with bilateral mid-lung plaques. So, ito ang keyword sa asbestosis, plaques. In the early stage of asbestosis, there is combined interstitial and pleural involvement causing a hazy ground glass appearance. Ito, hazy, medyo gray, hindi siya solid white, that may blur the diaphragm or blur the heart. So, another clue is a shaggy heart sign. Dito, mas may shaggy pa siya. Ito, shaggy heart. Kasi hindi mo na ma-delineate yung heart border kasi because of this. Ayan. Hindi mo na rin masyadong makita yung heart border details because of this shagginess. Honeycombing and upper lobe involvement will happen kapag advanced stage na siya. In the early stage, sa lower lobes muna siya pupunta. Fibrotic bands are superimposed on the background. So this is your, as I said earlier, this is your fibrotic band. Again, this is your busted CPA. So this is advanced asbestosis. One more. These are plaques. Sabi ko, yun ang magic word. Pleural plaques and also diaphragmatic plaques. So this is the very, very opaque white that you can see outlining the top of your diaphragm. Typical of an asbestos exposure. If you do an HRCT, this is a classic picture of a honeycombing. Pag sinabing honeycombing, it's like bahay ng bee. Ayan, puro butas. That's your blue arrow. Traction bronchiectasis. This is pagluwag ng airways. Ayan. This is tubular. I think this is tubular bronchiectasis. Ito din. Tubular bronchiectasis. Thick calcified pleural plaques. Ito. Which is the magic word for your asbestos-related disease. Again, traction bronchiectasis. This one, the green one. This is your honeycombing and this is your pleural. When we put the sample of washing or tissue under the microscope, we see asbestos body. So ito yun, itsura niya. And diagnosis relies on the history of exposure to asbestos with a proper latency period, which is what? 10 to 30 years. And then you need markers of exposure with sufficient quantities of asbestos fibers or bodies in bronchoalveolar lavage or biopsy. So ayan, we do that with scoping. Definitive evidence of fibrosis. So we can see that in CT scan, reduced lung volumes, we do that pulmonary function test, a typical radiographic findings, such as what I showed to you earlier, or the histologic evidence of interstitial fibrosis, plus any other disease that can absence of a differential diagnosis or exclusion. Like other occupational lung disease, the treatment is none. Supportive care can be offered, and of course, adopting a healthy lifestyle. This is a benign asbestos pleural effusions. I'm just putting it here because aside from thickening of the pleura, pwede rin magkaroon ng water. And I'd like to put this here because usually you find this before the onset of interstitial disease. Tapos, it goes away on its own. Tapos, pag nag-recur siya, interstitial lung disease na siya. Malignant mesothelioma, even if ito yung pinaka-notoriously correlated with asbestos, the most common cancer related to asbestos exposure is still lung cancer. But malignant mesothelioma is notoriously linked to asbestos also. It arises from the mesothelial surface of the pleural cavity and other cavities. But for this, because we're pulmo, it's plural. MPM is the most common type, and the symptoms are non-specific. Okay. Ako yata yung mag-need ng another cup of coffee. Okay, so I need you to refresh, or maybe you may need to pause this slide because the next would be a little bit heavy, but we're halfway there. Work-related asthma is divided into OA, occupational asthma, or work-exacerbate asthma. WRA is the umbrella term, again divided to OA, or work-exacerbated asthma. Occupational asthma is further divided into sensitizer-induced or irritant-induced. Yung definition in terms will come to the work-related asthma, which is the umbrella term, is refers to asthma that is exacerbated or induced by inhalational exposure, meaning kasalanan or pinalala ng trabaho. Okay? Now, work-exacerbated asthma refers to asthma triggered by various work-related factors, aeroallergens, irritants, or exercise in workers who are known to have, ito ang clue, pre-existing or concurrent asthma. Asthma that is occurring at the same time pero hindi po kasalanan ng workplace. Ulitin natin. Ang umbrella term is work-related asthma. Included here is yung asthma na lumala sa work or yung asthma na kasalanan ng workplace. A work-exacerbated asthma is may asthma ka na, pinalala lang ng trabaho mo. Hindi kasalanan ng workplace. No? Pumasok ka doon, may hika ka na. Pero because of exposure in your workplace, your asthma that, later we'll go in, your asthma tends to get bad or it tends to be exacerbated. Occupational asthma, ayan, refers to de novo asthma or the recurrence of a previously quiescent asthma. Yung mga sinasabi na childhood asthma po ako, wala naman po akong hika for the past 10 years, tapos biglang eto po ako, nagtrabaho, hinihika na po ako. That is occupational asthma. O, balik tayo. Wait. So, we'll go further first. So, occupational asthma can be sensitizer-induced or irritant-induced. Yung difference niya, yung sensitizer-induced are more organic or more protein, inhaled proteins. Ang irritant-induced, mas fumes, mas inhaled irritant at work with no apparent latency period. Parang biglaan. When the patient is exposed that day to that irritant, maghihika na siya. Agad-agad. Yung sensitizer-induced, may some latency pa yan as you build your hypersensitivity to it. Yung irritant-induced, right there and then, pwede kang magkaroon ng bronchoconstriction or wheezing or difficulty of breathing. The most definitive form of irritant-induced asthma is actually RADS or reactive airway dysfunction syndrome. I think I met parang 1 to 3 people with RADS already. And true enough, nung nilipat namin siya to another area of the same factory, the asthma went away or quieted down. Okay, so RADS is defined as an acute onset of asthma after a single, okay, clue, very high irritant exposure. So grabe yung fumes, grabe irritant ng fumes na-expose yung patient. These are examples of specific agents with sensitizer-induced OA. So, sabi ko sa inyo, medyo organic to. Plants, animals, bioaerosols. Okay. And then, irritant-induced OA are chlorine, ayan, smoke. Okay. So, maganda dito, parang occupational lang disease din yung RAD sa mga bumbero. Reactive airway disease, so as I said, a single massive exposure to an irritant gas and an immediate onset of asthma within 24 hours of exposure. So ito yung keyword nyo, 24 hours. Lumang pa siya dyan, di na siya RADS. Okay, hindi siya rats. Lampas ng 24 days rats. We have a diagnostic criteria of rats are the following. So you'll see it here, less than 24 hours. Okay. The diagnosis of work-related asthma. So ang WRA is the umbrella term. Nandun pa lang tayo. Umbrella term. First, you need to confirm or establish that there is indeed asthma. Asthma is a diagnosis. Hindi pwedeng, sabi po ng nanay ko, may hika po ako. Number one, you have to diagnose and establish the presence of asthma by objective means. And second, to establish that there is relationship with the work and the symptoms of asthma or the development of asthma. The possibility of WRA or work-related asthma should be considered in all adults who are currently employed. Okay, yung mga adults na may trabaho pala, hindi pala kasama yung mga tambay. And in those in whom asthma started or worsened during their working life. So ito na nga sila, mga may childhood asthma na nawala, bumalik nung working na sila. Meron ako magandang example dito. Sa childhood asthma, tapos he works as a casino dealer. So, ayun, isa siya doon sa occupational asthma. This is a summary flowchart of how to evaluate a patient with work-related asthma. Okay, maganda to. This is very simple and you can follow this if you do general practice after you graduate. So you consider diagnosis in all patients na nagtatrabaho na. So those are new asthma, work-related asthma, or worsening of asthma symptoms. So, yan sila. Yan ang chief complaint nila. Dok, hinihika po ako. Ina-attack po yung hika ko. Okay. Ang second mo naman sagot ay kawawa ka naman. Hindi. So, yung sumunod would be to confirm the asthma. So, ayan yun ha. Naku, very important yan. You confirm the asthma and you draft the onset. So, you do very, very thorough medical history coming from the childhood asthma and allergies. Then, you go with the symptoms. Kailan nagsimula? Paano ang nature? Do you wake up at night? So, you follow how the asthma lecture on how it's controlled or uncontrolled. You follow there and then you see the timing. So, as I said, pangit po ba to sa Monday to Friday? Maganda po ba to sa Saturday and Sunday when you're off? Pag nag-holiday po ba kayo, mas okay siya? You do a objective confirmation of asthma by spirometry. You know na we do bronchodilator challenge pre and post so that we can see response to bronchodilator. If hindi kaya, we can do as far as methacholine challenge. And then, once you confirm na, okay, may asthma nga my patient. Now, this is the time to assess exposures. So, you go into your occupational history, which is the first part of this lecture, and this is the following things that you're going to ask. What are the allergens or irritants? Baka naman, ano pala to, gardener, or shipbuilder, or nag-work sa pottery. So, ayun, sa akin, floor tiles. Ano yung trabaho niya doon, di ba? As I told you, you have to ask kung ano yung mismong ginagawa niya, not just the job title, but what you really do. Simula sa pag-upo mo sa workstation mo, anong hinahawakan mo, ano yung process, ano ang nilalagay mo, ano ang binubuksan mong container, and ano ang laman. You ask the ventilation if alam niya, and this is for you. You go as far as getting the material safety data sheets. You ask if may other patients, other co-workers with the same symptoms. And then you ask for environmental history. Kasi you not only need to establish yung causality sa occupational history, but you also have to exclude environmental history. And di ba, dun sa basic principle kanina, it's very difficult to distinguish both. So you will take time to go into the history of this patient. May pets po ba kayo? Yung pets po ba nasa loob ng bahay? May naninigarilyo po ba sa loob ng bahay? Or that's ambient air pollution inside the house. Once you've decided, okay, I did already the history. Now, ang next ko naman ay, what is the relationship of this patient's asthma to his work? So, you go again. Okay, I've covered this before na. The onset and timing and the severity related to work. Is there a dose gradient relationship? Pag mas mataas po ba yung exposure sa usok or sorry, sa dust? Mas hinihingal po ba kayo? Mas you find that you're in short of breath? You can do PFRs. I'll go to this later. Tuturuan mo siya mag-PFR sa mag-PEF sa trabaho versus mag-PEF sa bahay so that we will see if mas mababa ba yung expiratory flow niya, personal expiratory flow niya sa bahay, sa workplace versus nasa bahay. Ibig sabihin yun. I'll show you a graph later of PFRs. And then, kapag okay, mas masama nga yung asthma niya sa work. Now you can diagnose, okay, this patient has work-related asthma. Nakuha mo na yung step 1. Step 1 pa lang. Number 2, ang i-ask mo na sa sarili mo, is this occupational asthma or this is work-exacerbated asthma? Okay? So, if this, ano ba yung difference? Yung work-exacerbated asthma, may asthma na siya pagpasok doon lumala. Yung occupational asthma, doon siya nagkaroon. Or yung childhood asthma niyang quiet for the longest time, bumalik. Tapos, this is your management. Kasi, kapag occupational asthma, you have to decide if ang exposure niya is through a sensitizer or is it RADS, organ irritant. Kasi, syempre, you have to tailor fit. It's not just putting the patient on steroids or inhalers. You have to adjust the workplace or do recommendations. So, that's the beauty and probably yung pinaka-special part of occupational lung health, no? Magsusulat ka pa sa employer. Dear employer, I find this patient, ayan. And then you give your recommendation. Why is diagnosing OA important? So I was alluding to that because, as I said, it may not always be reversible, but it is definitely preventable. And affected workers may suffer potentially huge loss of wages. Early removal from exposure leads to better prognosis, and many industries require proof na talagang kasalanan nila before nila gastusan yung patient. Okay? Kasi I said it's compensable. Okay? By insurance, pwede silang bayaran. The main risk factors for OA is, again, what is the causative factor? Sino ang may sala? Anong exposure? Anong dust yun? Anong predisposing factor ng patient? Talaga bang may asthma siya? Genetic predisposition? Is he atopic? Contributing factors would include cigarette smoking. Ayan. So, kasama yun sa environment. This is another algorithm, how to do assessment of possible occupation asthma. Parang itutuloy mo siya dun sa kaninang algorithm ko. So, you consider, kasi pinaka-bulk ng lecture ko yung occupation asthma. So, kukulitin ko kayo on this. Ask adults with possible asthma, new onset, unexplained deterioration of asthma, and those with airflow obstruction less than 0.7. Tatanungin mo siya, anong current work? Is it better on rest days or holidays? Or, tanungin mo na rin, do you think nakaka-affect yung work mo? Meron pa yung asthma that's worse in bakers kasi daw yung flour can cause also exacerbation of their asthma. Work effect, so ito yun, we've done that. Pag diagnosis is unclear, refer to a specialist. If you have already diagnosed it as an occupation asthma, you will advise on employment and you would advise compensation. So I think yung patient ko, hindi naman siya nawala ng work, but the recommendation was, pwede po ba siyang lumipat ng area? Kasi his asthma is getting severe dun sa area na yun. And true enough, the employer was very cooperative. So when we moved the patient to another area, his asthma was able to be. How to recognize occupational asthma? Does the individual have asthma? Yun yung unang tanong, di ba? Establish the diagnosis of asthma. Yun yung number 1. Yung number 2 kanina was to establish the relationship with the work. Does the individual have asthma? So ito yung symptoms. As I said, get an objective confirmation of asthma. And then you do a serial PEF. What is increased diurnal variation? Kasi diba in asthma, minsan may mga patient na mas malala sa gabi, at night, may mga temporality yan sa buong araw. Nagpa-fluctuate yung PEF nila ng mga asthmatics. Yun yung difference with COPD kasi walang diurnal variation. You now ask to answer if the patient has asthma to test for airway hyperresponsiveness. Through what? To methacholine challenge. Alam mo yung minsan, later, we'll go there. Yung extreme form is, ilalagay mo siya back to the environment or the exposure, tapos dun mo siya i-PPEF. But that is not ethical and should be monitored closely. So in lieu of that, you can do methacillin challenge. Most useful if the spirometry is normal. Kasi di ba, a normal spirometry does not always rule out a bronchial asthma. Methacillin challenge can be used if the PFT is normal. You can test for atopy, ito yung mga skin prick test, and do imaging to exclude other disease. Baka naman pala silicosis ito. Hindi naman pala siya occupational asthma. Once you've confirmed asthma, yung number 2 question natin kanina, is it occupational origin? So these are the questions. Nasabi ko na, is it worse at work? Is your PF worse at work? Basically yun eh, mas masama po pa siya pag nasa work kayo. Symptoms and then PEF. This is it. The return to work broncho vocation BPT study. Okay, I haven't heard of this. So, done yet by theory. Okay? So, this is peak flow monitoring at home at work. So, makikita nyo na here, nung patient, so, mas mataas yung peak flow monitoring niya sa bahay kasi wala siya sa exposure. Tapos makikita mo dito, pag sa work, babagsak siya. No? Babagsak siya. Tapos, makikita mo na pabagsak siya, nag-start siya ng Monday, dito siya. Tapos, by Friday, 300 na lang yung peak flow monitoring niya. Tapos, aakyat siya ulit kung kailan weekend. Ayan, nag-improve siya sa weekend. O, diba? So, this is the peak flow monitoring of example of a patient with occupational asthma. This one, you would diagnose occupational asthma if there is a 20% diurnal variation more often at work than off work. If more than 20% is not often sa work, asthma lang siya. Wag nating sisihin ng workplace. It's just plain asthma. Okay, but it's indeterminate pag minsan tataas sa sobra, tapos minsan on different days. In short, walang pattern. Sorry. So it's indeterminate. Management, usual. Like the usual treat as an asthma. Okay, sabi ko nga, ang ending naman pala, LABA ICS din. But apparently, this can be compensated. The patient can be compensated. You can do changes in the workplace. May mga coworkers na masisave ka from future asthma. And then you can advise cessation of exposure to an inducing agent. Kasi syempre, yung other pang employees. If continued employment, so this is what we did, minimize the exposure, and then do a suggest a surveillance program to assess progress, and then of course. So when we manage the workplace, we start with identification of inducing agent. Next, we go on environmental characterization to establish exposure levels associated with task and sites. No? And then we do or recommend alternative production process. And if you cannot really avoid the use of inducing agents, then we recommend environment hygiene improvements. What are other steps to manage the workplace? Well, of course, we can initiate or at least recommend surveillance programs that are intended to monitor exposure levels and establish compliance with regulatory exposure controls. Medyo ano nito, occupational health masterals. We can also manage the workplace with the surveillance of the workforce to establish the extent of problems. So we can do, siguro the clinic can start screening employees in the same areas kung meron ba sa kanila with the same symptoms as your patient. And then, we can prepare written essential information for the workforce. O kapag you find your symptoms to have the following, kindly call the clinic, ayan, so that we can catch these patients early. The symptoms and functional impairment may persist for many years after the avoidance of further exposure to the causative agent. Parang kanina, even if the exposure as finished na, as I said, pwedeng progressive decline pa din yung mga patients with silicosis, ganun din sa occupational asthma, kahit you've removed them from the workplace. But again, kahit parang it can still deteriorate, you would still remove the patient from where the inducing agent was. The likelihood of improvement or resolution of symptoms or preventing deterioration is greater for those who have No further exposure. So, ayun, tatanggalin na nga natin sila. Relatively normal lung function at the time of diagnosis. Siyempre, kung may COPD sila, o di, ano na, COPD as OA, overlap na siya. Mas less yung likelihood of improvement of those patients. Whereas yung bata pa, pagpasok, tapos doon lang nagka-OA, pag tinanggal, then there's a greater likelihood of improvement. And then, if there's also shorter duration of symptoms prior to diagnosis and to avoidance of exposure. So this is what we did, or what I did for my patient with deployment to a low exposure area. And since I told you earlier na yung treatment of occupational asthma is the same as the usual asthma, inhaled corticosteroids can be used. But, well, it can provide small clinical benefit. Still benefit, diba? Okay. All right, we're down to the last 10 slides. You can get yourself a cup of coffee. It'll be a little bit boring, but this is the managerial and administrative aspect of occupational lung health. So we start with the fundamentals. There are three factors or fundamentals of control of occupational lung disease or any other disease. It lies in the controls in the admin, controls of the environment, and the personal respiratory protection or PPE. Napakadali lang nito. Number one, prevention. The use of asbestos has already been eliminated. Parehas ng sandblasting with sun. Honestly, hindi ko naman alam kung ano yung sandblasting with sun. Pero, yan yung historic way of having silicosis. Tapos, binana din siya. Number two, or step two is engineering changes. So that apparently using water will minimize the emission of dust during cutting of stone and concrete. Tapos ang pinaka naaalala ko lang this is, di ba kapag magabok yung road sa highway, yung mga nakatira sa tabi ng kalsada, tinatapunan nila ng tubig. Para pag tumadaan yung mga truck, o kasi sa province ako pinalaki, ganun eh. Pag tumadaan yung mga truck, hindi masyadong magabok doon sa bahay nila. Kasi nilalagyan nila ng tubig. So I guess that's the same principle. To minimize emissions of dust during cutting of stone and concrete, maglalagay sila ng water. Another engineering change is using process containment. Alam niyo ba na this is how chemotherapy drug is also being mixed sa loob din ng isang ganyang container. So that minimize the exposure of this woman to the fumes inside. Papasok niya yung kamay niya doon, and that is probably controlled temperature-wise, pressure-wise. Step 3, adjust the work practices. You reduce the exposure time kung di talaga matiis eh. It's part of the process then. For example, reducing exposure time. Yung mga radiologists, they have this monitor of radiation. So, pag may time na sobra, papahinga na sila from the radiation exposure. Ganun din, siguro, I'm not really sure how technical that is, but that's probably a good idea for dust exposure. You increase the distance, you change your work methods, and then you initiate or implement standard SOPs on how things should be handled carefully. And number 4, which is the last resort, PPE. Kasi you're just protecting one individual. And the dictum of population health is, diba, protect the many. No? It does not address the source. It is usually not as cost effective. Because tapon ng tapon yan. Tapos it's uncomfortable to wear and compliance is an issue. So for example, yung mga construction sites sa Skyway, talagang lahat ba sa kanila naka-safety hat or lahat sa kanila naka-safety boot. So very difficult to induce compliance. Especially kung nakamask. Tayo nga hirap na sila pa kaya na nasa very, very humid or very physically taxing workplace. So that's it. Thank you and congratulations. You made it at the end of the 90 slides of occupational lung health. Probably the most boring of your module. Thank you for your attention. If you have questions, please email me at the email below. Thank you.